A very good morning to all of you. With the permission of Chairperson, I'm presenting some different tests in front of you. So my case is a slightly different intervention in a case of stroke. So we will go through go in a case. So my case is a 52-year-old male. He's a non-hypothyroidist but well controlled with the thyroid drugs. He's a slightly dyslipidemic. Other factor known is non-hypertensive, non-diabetic and non-smoker. And he presented in neurology department with the history of left side weakness for 1 day, and this was associated with the vertigo. On examination, blood pressure is within normal limit. He's well alert, conscious. He has a slight weakness on left side and left plantar was extension, and other things are within normal limits. He has slight anemia and other things normal. MRI shows patchy acute infarct in left cerebral hemisphere, and which is suggestive of border zone infarct. He underwent carotid Doppler, and which shows 80 to 90% luminal narrowing in the right IC. So then this case was referred to us for DSA, and this is the diagnostic angiogram DSA. It shows nearly 95 to 99% occlusion of the ICA, internal carotid artery ostium. So this is a patient presented with a stroke, and this is the second day after the stroke, and with the minimal weakness. So we want to salvage as much as possible, because in the literature we can see that in the first week or after 2 weeks there are more chances of developing the full-blown stroke. So patient and family was counseled for carotid angioplasty. We put a 7 French shuttle sheath from the right groin into the CCA over the implazer wire. Till then everything is fine. I mean, as soon as we remove our guide wire through the ECA, the patient has some involuntary movement and had slurring of speech. We want to talk to him, but he couldn't say what he wanted to say, and he suddenly becomes tachypnic. He had tachycardia and BP raise. He couldn't move his left side and is only moving his right side. He was very dead. So we took another angiogram with the shuttle sheath, and now we can see there the complete occlusion of the IC from the ostium. So a patient intubated immediately, and GA was administered because patient was very agitated at that time. And after that, blood pressure and heart rate was partially controlled. So now the options to us are whether we should terminate the procedure and do a systemic IV thrombolysis, which is the standard for a case of acute stroke within 4.5 hours. Or we have an intra-arterial ulcers. At that time we can go ahead with the intra-arterial thrombolysis. There is a role of GP2B3 inhibitors, but there is a controversial role in the acute thrombus. We can continue procedures with the distal protection device, or if there is a large thrombus, we can continue without. So we have lots of options in our mind what we go ahead. So what we proceed, we just give an intracarotid tirofiban because we thought this is acute thrombus formation. We may get away with GP2B inhibitors as a bolus dose in the carotid artery, but there is no flow. Then the second step we have intra-arterial access, so we tried intra-arterial thrombolysis with the LT place. And this is the picture just after intra-arterial thrombolysis, a very small trickling of flow now going into the ICA. So with this small flow, we have decided to cross the lesion, and with the help of the multi-purpose coronary catheter, and we put a normal routine coronary wire across that lesion, and we are lucky enough to just after crossing the wire, there is a sufficient flow into the cerebral circulation, and there is no intracerebral migration of the thrombus at that time. So we just did a balloon dilatation at the local site, and followed by we put a self-expanding stent just after that. This is the neutrino stent, 16:8, 40 millimeter long stent, and this is the picture after putting a stent. So there is small residual stenosis at the bifurcation site, but there is a good flow into the distal ICA and the intracerebral circulation. So we waited for 15 minutes on the table, and there is no deterioration in the flow, no thrombus formation. We didn't do the post-elevation because we have a risk to migration of the that thrombus which was covered by the stand. Then patient shifted to ICU and extubated after 2 hours. Patient recovered well, and we are lucky enough that he doesn't have any residual weakness on the day of discharge on day 3rd. The rare things in this case, this is a rare case of acute stroke in front of us in Cath lab. All the options were tried. We did this thrombolysis, we give a GP2 diameter and then complete the carotid intervention. The things to learn, we should not panic and we should discuss what the options available to us, and critical care team is very helpful in this situation to